This recording will cover part 2 of pneumonia. We're going to start off with what are our priority problems in our patient with pneumonia. So we're talking about a patient with a lung condition. So decreased gas exchange is a high priority problem. Potential for airway obstruction, another high priority problem. Potential for sepsis. Remember, once the patient becomes septic, that means the infection has moved to the bloodstream, a very deadly complication. And finally, potential for pulmonary empyema. And remember, pulmonary empyema is a buildup of that exudate or pus in between the lung and the chest wall in that pleural space. So in regards to interventions, we're going to talk about what we can do to prevent pneumonia, things we can do to improve gas exchange, prevent airway obstruction, prevent sepsis, and manage empyema. So let's look at some things we can do to prevent pneumonia. We can do things that limit the risk of infection, such as hand washing, also vaccinations, both annual influenza vaccines and pneumococcal vaccines. There's two types. CDC recommends Prevnar 13 first, followed by Pneumovax 6 to 12 months later. If a patient happens to receive Pneumovax first, that's fine. They just need to wait a year or more before they receive the Prevnar 13. Vaccinations are recommended for those 65 years of age or older, and those patients who are ages 19 to 64 who have specific risk factors such as chronic illness. We also want to advise patients to avoid crowds during flu and holiday seasons. Patients with mobility issues, those who aren't moving much, should be doing deep breathing exercise, coughing, turning, moving about as much as possible. We want to make sure patients understand how to maintain and clean any respiratory equipment. We want to encourage them to avoid indoor pollutants such as dust, aerosols, and smoke. We ask that they use sterile water rather than tap water for G-tubes just in case there is aspiration. And we want to make sure we use aspiration precautions as indicated and screen patients for aspiration risks. Preventative care for ventilator-associated pneumonia includes the head of the bed being at least 30 degrees elevated, oral care regimen, suctioning, and hand hygiene. Other ways to limit the risk of infection include encouraging the patient to be healthy and hydrated. They shouldn't smoke, they need to get enough rest, eat a balanced, healthy diet, and drink at least 3 liters of fluid daily. Interventions to improve gas exchange include oxygen therapy, incentive spirometry. We could add in here pulmonary hygiene, which would include the coughing, deep breathing. What else could we add in there? Ambulation. Remember, movement is important, especially for the prevention of pneumonia. So getting up, getting out of bed, getting vertical is helpful. Walking gets those lungs expanded, can promote coughing. The goal with gas exchange is to have no signs and symptoms of hypoxia or hypoxemia. Preventing airway obstruction, the goal would be to have no signs and symptoms of hypoxia and effective coughing, right? We want to be able to cough up that mucus so it doesn't plug up our airways. We want to teach the patient to cough and deep breathe every 2 hours, to use the incentive spirometer, drink at least 2 liters of fluid to prevent dehydration and help thin those secretions. And also medications can help improve the risk for airway obstruction. I added meds up here for improved gas exchange also, right? Those bronchodilators, there are medications that will help improve gas exchange. So interventions for preventing sepsis. Remember that the patient with sepsis has an increased risk of death. So we want to use sepsis screening tools and be monitoring for that spread of infection, be watching for signs and symptoms of sepsis. Big ones include the blood pressure dropping, the heart rate increasing. We also want to make sure the patient is receiving anti-infectives, right? The antibiotics or the medication they're taking to treat their infection is going to control the infection in the lung and prevent it from spreading into the blood. ARDS treatment is necessary. We want to watch for aspiration of food and stomach contents, which can cause ARDS. The goal would be that our patient is afebrile, has negative sputum and blood cultures, and that the patient's white blood cell count is within normal limits. In regards to managing empyema, again, empyema is a collection of pus in the pleural space, most commonly caused by a pulmonary infection. Signs and symptoms of empyema include chest wall motion reduction, fremitus is reduced or absent, breath sounds decreased. This can be diagnosed with a chest x-ray or CT scan. Also, a sample of the pleural fluid from a thoracentesis can also lead to diagnosis. Empyema fluid, remember it's pus, it's exudate, it's thick, opaque, and foul smelling. Treatment of empyema includes draining the empyema cavity with a thoracentesis and re-expanding the lung to control infection using antibiotics and chest tube if necessary. So let's look at our medications used to treat pneumonia. The first one we have listed is the beta-2 adrenergic agonist. That should be your best friend in these respiratory chapters. If you feel uncomfortable about albuterol or that classification of medications, you need to review it. It works by causing bronchodilations when bronchospasm is present. So it's opening up those airways, allowing for better oxygenation. Corticosteroids are anti-inflammatory. Remember, these are the medications that end in "-son" or "-solone". Mucolytics, you see lytic, you should think of breaking down muco, meaning mucus. So it loosens secretions so they're easier to cough up. And guaifenesin is your prototype mucolytic you need to recognize. And then finally, anti-infectives. If we're talking about an infection, the patient needs to be taking a medication to treat that infection. So what type of medication they're prescribed really depends on the infection. Is it bacterial? Is it fungal? Because that'll play a role in how it's treated. In terms of patient education, we want to talk to the patient about energy conservation. When the patient's sick with pneumonia, they can experience a lot of fatigue, and especially with the older adult, that fatigue can last a long time. So after discharge for weeks, they can feel pretty cruddy. So we want to talk about energy conservation at home. Maybe we need to change where the bed is, things of that sort. Long recovery phase, again, especially for older adults. Fatigue, weakness, and cough can last for weeks. We want to make sure they understand their drug therapy, what meds they need to take, what they do, how long they need to take them, what side effects they might want to watch for. We also want to let them know about signs and symptoms of infection, maybe signs and symptoms of the infection getting worse or a complication. We want to encourage the patient to rest, avoid infection and irritants. We've already talked about prevention. Have a balanced diet and adequate fluid intake, and to stop smoking if they are smokers or not start if they don't. And finally, pneumonia evaluation. So what do we expect? What's our goal for our patient with pneumonia? It's to return to their baseline health status, to have adequate gas exchange, a patent airway, no signs and symptoms of infection, and to avoid sepsis and empyema.